Everyone thought she was just a night shift nurse, but that night everything changed. The cardiac monitor was shrieking as 8-year-old Emma's heart rate spiked dangerously high. "She's going into cardiac arrest or doctor," Harrison said frantically, fumbling with the defibrillator paddles. "The pediatric crash cart isn't responding. We need to call for emergency transport." But the night shift nurse, Lisa, was already preparing an emergency pericardioentesis kit with surgical tubing and a large bore needle. "This will save her," she said with calm precision. "I've drained fluid from hearts in combat zones with battlefield equipment." Sometimes the person who can perform the most complex procedures is the one everyone thinks just does routine nursing tasks. Welcome to Hidden Legends. Before we dive deeper into this incredible story, tell us in the comments what city you're watching from today and hit that subscribe button. Lisa Johnson was 35 years old. Her blonde hair always in a practical ponytail, working seamlessly through her night shifts at Memorial General Hospital as a nurse. For the past 4 years, she had been a figure that people barely acknowledged. Efficient, reliable, forgettable. The night shift was demanding work. Skeleton crew, critical patients, attending physicians who were often exhausted residents. Lisa's responsibilities seemed straightforward. Routine patient care, medication distribution, checking vitals, bringing doctors whatever supplies they requested without question or recognition. Dr. Harrison, a third-year resident, treated her like an assistant nurse. When he needed extra gauze or fresh coffee during long procedures, Lisa was the one he called. Head nurse Williams assigned her routine tasks, medication inventory, updating patient files, assuming the night shift meant a lighter workload. Hospital administrator Dr. Taylor never gave her special attention, just seeing her as one of the night shift nurses. Night shift staff were generally overlooked, just invisible cogs in the hospital's operation. Lisa had accepted this invisibility. 4 years of identical routines. Complete your tasks without drama. Avoid confrontation. Stay unnoticed. Never discuss your superior medical skills. Because as she walked those sterile corridors, she carried a burden on her shoulders that no one could ever imagine. Every night she started her shift at 7 p.m. She would arrive 15 minutes early, receive detailed patient handoffs from day staff, and settle in for the hospital's transition to its quieter, more vulnerable overnight rhythm. Night hospitals operated differently, less bustling activity, but higher stakes when emergencies erupted with minimal backup support. But this is where everything changed. Evening shifts began at 7 o'clock p.m. sharp. Lisa consistently arrived 15 minutes early, received detailed handoffs from day staff, and settled into the hospital's transition to its quieter, more vulnerable overnight rhythm. Night hospitals operated differently, less bustling activity, but higher stakes when emergencies erupted with minimal backup support. This particular evening, Dr. Harrison seemed unusually agitated. He had requested his 4th cup of coffee, and when Lisa delivered it, she accidentally knocked over a stack of patient charts. Dr. Harrison lectured Lisa about being more careful, emphasizing that patient documentation was critically important. Lisa apologized and collected the scattered files. While reorganizing them, she noticed a chart for Emma Davis in the pediatric cardiac unit. 8 years old, congenital heart defect, post-surgical monitoring, stable but requiring careful observation. Because Lisa carried secrets, experiences that no one in this sterile civilian world could comprehend. Walking these clean corridors, she had a past no one knew about. Filled with blood, sweat, and uncertainty, years spent on the thin line between death and life. Lisa Johnson was actually a former United States Army combat medic. She had enlisted at 22 and completed 9 years of active duty. 2 combat deployments in Afghanistan, 1 in Iraq, stationed at forward surgical teams, mobile Army surgical hospitals, casualty collection points wherever critical medical intervention was desperately needed. She had trained as a 91W healthcare specialist, managing blast injuries, gunshot wounds, severe burns, multi-system failures, often without proper ventilators, adequate blood supplies, or reliable electricity. She improvised life-saving treatments using whatever materials were available. In Lisa's mind, those endless desert nights were still vivid. Working under incoming mortar fire during extended blackouts, performing emergency surgery using headlamp illumination. Every procedure was a test, every decision a matter of saving or losing a life. You haven't seen the biggest surprise yet. Lisa's most challenging experiences had occurred during those endless desert nights, working under incoming mortar fire, during extended blackouts, performing emergency surgery using headlamp illumination. During one particularly intense firefight near Kandahar, she had simultaneously stabilized 6 critically wounded soldiers after a convoy ambush. Using only essential field equipment. She had worked for 4 straight hours. 4 hours straight without stopping, without taking a break. Every soldier survived that night. Every single one. And Lisa knew it wasn't just luck. It was training, discipline, and the ability to think clearly under impossibly high-pressure situations. That night, after the convoy ambush, Lisa found herself in total chaos. 6 wounded soldiers, multiple blast injuries, minimal equipment, and constantly incoming fire. But she didn't panic. Training kicked in. The first soldier had massive chest trauma, collapsed lung, probable internal bleeding. Lisa immediately performed needle decompression, then prepared improvised equipment for chest tube insertion. The second soldier had severe abdominal wounds. Lisa used combat gauze and pressure bandages to control bleeding. The third soldier was unconscious with head trauma. Lisa secured the airway, immobilized the cervical spine, continuously monitored vital signs. The fourth soldier had multiple fragment wounds. Lisa quickly triaged, treating life-threatening injuries. First, the fifth soldier had cardiac rhythm problems, probable cardiac contusion from blast effects. Lisa set up EKG monitoring, established 4-axis, prepared cardiac medications. The sixth soldier had severe burn injuries. Lisa applied cooling techniques, initiated fluid resuscitation, and while doing all this, mortar rounds were constantly falling, dust and debris flying everywhere, communication equipment barely working. But Lisa stayed focused, maintained a systematic approach, prioritized appropriate treatment for each soldier. After returning from each deployment, Lisa never shared the real details with her family. Everything went fine was her standard response because those traumatic scenes, young service members fighting for their lives, the weight of making split-second decisions that determined who lived and died, these were realities that civilians should never have to process. In Lisa's mind, those moments remained crystal clear. Every wounded soldier's face, the weight of every critical decision, the relief of every successful save, and unfortunately the devastating impact of every loss. These experiences had changed her, shaped her at a deep level. Following her honorable discharge in 2020, she had craved normally. No explanations about military service, just the quiet satisfaction of being an unremarkable night shift nurse. This invisible existence gave her peace. No pressure, no expectations, no responsibility to constantly make life and death decisions. This particular evening, Dr. Harrison seemed unusually agitated. He had requested his 4th cup of coffee, and when Lisa delivered it, she accidentally knocked over a stack of patient charts. Dr. Harrison lectured Lisa about being more careful, emphasizing that patient documentation was critically important. Lisa apologized and collected the scattered files. While reorganizing them, she noticed a chart for Emma Davis in the pediatric cardiac unit. 8 years old, congenital heart defect, post-surgical monitoring, stable but requiring careful observation. Lisa quietly mentioned to Dr. Harrison that Emma's heart rhythm seemed irregular on the monitors. Harrison barely glanced at the data and reminded Lisa that although advanced cardiac interpretation was already her specialty area, there wasn't enough time for such detailed analysis. When Lisa attempted to point out specific abnormalities in Emma's EKG patterns, Harrison became irritated. He explained that basic monitoring was sufficient and detailed analysis wasn't needed right now. Lisa nodded respectfully and stepped back, but her attention remained fixed on Emma's telemetry readings. Something critical was developing that everyone else was missing. At 3:15 a.m., urgent alarms began sounding from Emma's room. High-pitched continuous tones indicating immediate life-threatening emergency. Lisa rushed to the bedside. Emma's cardiac monitor showed dangerous arrhythmias. Her blood pressure was plummeting and her oxygen saturation was dropping rapidly. The 8-year-old was becoming unconscious, her skin turning pale and clammy. Dr. Harrison arrived moments later, clearly panicked. "What's her status?" Lisa quickly assessed the situation. Emma's neck veins were distended, her heart sounds were muffled, and she was showing classic signs of cardiac tamponade, fluid accumulation around the heart preventing normal cardiac function. Dr. Harrison attempted standard resuscitation protocols, but Emma's condition continued deteriorating. "Her heart rate is erratic. Blood pressure is critically low," he said desperately. Nurse Williams appeared, asking if they should prepare for emergency transport. Dr. Harrison explained that Emma was too unstable to move, but the pediatric cardiac surgery team was at least 30 minutes away. Williams suggested calling the code team, but Emma's cardiac rhythm was becoming increasingly chaotic. Traditional approaches were failing, and Emma's life was rapidly slipping away. Emma's vital signs were failing. Her heart was being compressed by accumulated fluid, unable to pump effectively. Lisa stood observing from the corner, recognizing the exact pathology from her military medical training. Dr. Harrison was overwhelmed. Williams was out of her depth and Emma was dying from a condition that Lisa had treated multiple times in combat hospitals. Lisa remembered every moment of the past 4 years when she had concealed her qualifications. Every time she'd let others assume she was just basic nursing staff, but now an 8-year-old was minutes from cardiac arrest, and she possessed every specific skill needed to save her life. Meanwhile, in Lisa's mind, past experiences were flooding back. That night in Kandahar, when a young soldier was struggling with cardiac tamponade, exactly the same situation. Blast injury, fluid around the heart, rapidly failing vital signs. And Lisa knew exactly what to do that night. Combat medic training was comprehensive. Soldiers could encounter a variety of medical emergencies and field conditions. Cardiac tamponade was relatively common after blast injuries. Pericardioentesis was a standard procedure, a life-saving technique that could be performed even without specialized equipment. This is where everything changed. Lisa calmly approached Dr. Harrison. Harrison told her this wasn't the time for nursing questions and to prepare medications for the incoming code team. "I can perform the procedure she needs," Lisa stated clearly. Harrison turned looking confused and reminded Lisa that she was a floor nurse not qualified for advanced cardiac procedures. "I can perform emergency pericardioentesis." Lisa said, "I can drain the fluid compressing her heart." Everyone in the room stared. Williams asked what she was talking about. "Using a large bore needle with ultrasound guidance, I can access the pericardial space and remove the fluid. It's Emma's only chance." Dr. Harrison laughed nervously and told Lisa this was a complex surgical procedure, not something nurses performed, especially with a child's life at stake. Lisa met his gaze with unwavering confidence, and her voice carried an authority no one had heard before. "I'm qualified to save her life." And then what happened shocked everyone. Lisa moved with military precision. She gathered supplies from the crash cart, located the portable ultrasound unit, and began preparing sterile equipment. Williams asked what she was doing. Lisa didn't explain. She was positioning Emma properly, cleaning the injection site, calibrating the ultrasound to visualize the heart and surrounding fluid. Dr. Harrison was still attempting conventional resuscitation, but Emma's cardiac function was failing. Nothing's working. How long until the surgical team arrives? Williams checked her phone and said at least 25 minutes. Harrison realized Emma wouldn't survive that long. Lisa had assembled her improvised pericardioentesis kit. It wasn't ideal equipment, but it was functional. She had ultrasound guidance, sterile technique, and the precise anatomical knowledge needed for this life-saving procedure. "Ready," Lisa announced. Dr. Harrison looked at her setup and asked what it was. Lisa explained it was emergency cardiac decompression. She would remove the fluid, preventing Emma's heart from beating effectively. Dr. Harrison questioned whether it was safe. Lisa looked directly at him and said, "I've performed this procedure on wounded soldiers under mortar fire." The room went completely silent. Williams asked what she meant by that statement. Lisa explained that during her deployment in Afghanistan, she had performed emergency pericardioentesis on service members with cardiac tamponade from blast injuries, often in field conditions far more challenging than this hospital room. Dr. Harrison stared at Lisa with complete surprise and asked how this was possible. Lisa revealed that she was a former Army combat medic, had served 9 years active duty, and had extensive experience with battlefield trauma surgery and emergency cardiac procedures. Emma's blood pressure was becoming undetectable. There was no time for further discussion. "You haven't seen the real shock yet." Lisa positioned the ultrasound probe to visualize Emma's heart. She could clearly see the fluid collection compressing the cardiac chambers. Using sterile technique, she inserted the large bore needle with precise guidance. The procedure worked perfectly. Dark fluid immediately began draining from around Emma's heart. Her cardiac rhythm stabilized, blood pressure began recovering, and her oxygen saturation improved. "How did you know exactly what to do?" Dr. Harrison whispered in amazement. Lisa explained that cardiac tamponade was a common injury pattern in blast trauma cases, and emergency pericardioentesis was a standard combat medical procedure that she had performed dozens of times, under much more difficult circumstances. Williams continued staring and asked if she was really a combat medic. Lisa confirmed she was a 91W healthcare specialist who had completed 2 deployments in Afghanistan and 1 in Iraq, specializing in trauma surgery and emergency cardiac procedures. Williams asked why she had never mentioned this background while monitoring Emma's improving vital signs. Lisa explained that she had wanted to work as a regular nurse in civilian life without her military experience creating complications or expectations. Dr. Harrison was still processing the situation and asked where she had learned such advanced medical skills. Lisa replied, "Comatic medicine teaches you to perform whatever procedures are necessary to save lives. Equipment limitations and challenging conditions become irrelevant when someone is dying." Emma's heart rhythm had normalized completely. Her blood pressure was stable and her color was returning to normal. Dr. Harrison asked if the procedure would provide lasting stability until the cardiac surgery team arrived. Lisa explained the immediate crisis was resolved, but Emma would need surgical evaluation for the underlying cause of the fluid accumulation. When the cardiac surgery team arrived, Emma was stable and alert with normal vital signs. The surgeons were impressed by the quality of the emergency pericardioentesis. The lead cardiac surgeon asked who had performed the procedure. Dr. Harrison indicated Lisa and explained, "Our night shift nurse is actually a former Army combat medic." The surgeon looked at Lisa with professional respect and asked about her military medical background. Lisa described her service as an Army healthcare specialist with extensive trauma surgery experience in Afghanistan and Iraq. The surgeon praised the technical execution and said the procedure had undoubtedly saved Emma's life. After Emma was transferred to cardiac surgery for definitive treatment, the hospital corridors felt different, charged with a new awareness of what had just occurred. At this point, nothing would ever be the same. Dr. Harrison approached Lisa and apologized for underestimating her advanced qualifications and true capabilities. Lisa assured him that he couldn't have known about her detailed military medical background and that she had deliberately kept her combat medic service private. Williams also apologized for giving her routine nursing assignments clearly far below her true capabilities when she was capable of much more advanced medical intervention. Hospital Administrator Dr. Taylor arrived to review the incident and met Lisa with genuine respect. For the first time, he addressed her formally as Senior Nurse Johnson and commended her exceptional performance during the medical emergency. Lisa maintained that she had simply done what was necessary. Dr. Taylor emphasized that her actions were far beyond standard nursing protocol and that the hospital was fortunate to have someone with this level of expertise on staff. Word quickly spread among the medical staff. The night shift nurse was actually a decorated combat veteran who had performed an advanced medical procedure that saved a child's life. The story became legend in the hospital. Lisa returned for her next shift, but the atmosphere had completely transformed. She was no longer invisible or overlooked. Dr. Harrison sought her input on complex cases and asked for her clinical opinions. Lisa welcomed the collaboration. Williams brought her coffee and insisted that Lisa deserved to rest while others handled the routine tasks. Dr. Taylor prominently featured Lisa's name in the hospital's incident report, highlighting how night shift nurse Lisa Johnson's exceptional medical expertise had prevented a pediatric fatality. Most significantly, little Emma Davis had made a full recovery. Her family visited to express their gratitude to the nurse who had saved their daughter's life. Emma's parents thanked Lisa for her quick thinking and skilled intervention. Lisa modestly explained that she had used her medical training when it was needed most. The parents emphasized that Lisa's expertise and compassion had given their daughter a second chance at life. Other hospital staff members also began looking at Lisa differently. There was respect and admiration in their eyes. They saw her not just as a nurse, but as a lifesaver, a hero. Young residents began seeking medical advice from Lisa. Experienced nurses valued her opinion. Hospital administrators considered position upgrades. But Lisa remained humble. She wasn't seeking the spotlight. She simply wanted to do her job, help people in need, and continue her service. Even though the uniform was different, no one could have known that. Driving home that morning, Lisa reflected on the events. For 4 years, she had intentionally remained anonymous because after her military service, she had wanted a simple, uncomplicated civilian career. But sometimes the most routine situations require the most extraordinary interventions. Sometimes concealing your capabilities ensures you're present when those skills become essential to saving a life. Lisa sat in her car leaning against the steering wheel. The emotions were overwhelming. After 4 years, she finally felt like she could be her true self. She didn't have to hide her background, her skills, her experience. The transition from military to civilian life was always challenging for veterans. Identity loss, lack of purpose, underutilization of skills. These were common problems. But Lisa had chosen a different path. To be invisible, to blend in, to live a normal life. And now she realized that maybe that was the wrong approach. Maybe hiding who she was, denying her training, suppressing her capabilities. Maybe this was a waste. Not just for her, but for the community, for her colleagues, for patients who could benefit from her expertise. Emma's case was just the beginning. Word spread throughout the hospital, circulated in the medical community. Lisa's story became an inspiration for other veterans struggling with transition, identity, purpose. The hospital gave Lisa formal recognition, certificate of excellence, commendation letter, even a monetary bonus. But the most meaningful recognition came from Emma's family, a handwritten thank you note, her daughter's drawing, and an invitation to a family dinner. There was also media attention, local news story, veteran organization feature, medical journal mention. Lisa was initially hesitant about the publicity, but realized the story carried an important message. The value of veterans' hidden talents, service continuation in different forms. Speaking engagements came, medical conferences, veteran events, hospital training sessions. Lisa reluctantly began accepting because the message was important. Veterans are valuable assets for the civilian community. Their skills are relevant and transferable. Service never truly ends. Years later, Lisa's career transformed. The hospital created a special position for her, Emergency Response Coordinator, a role that utilized her military medical experience. She developed training programs for other veterans transitioning to healthcare. Emma grew up healthy and strong. She went to college to study medicine. The life-saving experience had inspired her career choice. She occasionally visited Lisa as a mentor, role model, the person who saved her life. And Lisa finally found peace with her identity. She could be a military veteran and civilian professional at the same time. She didn't have to deny her past to embrace her future. Service continued in a different uniform, in a different setting, but with the same commitment to saving lives, helping people, making a difference. Lisa's story isn't just a heroism story. Driving home that morning, Lisa reflected on the events. For 4 years, she had intentionally remained anonymous because after her military service, she had wanted a simple, uncomplicated civilian career. But sometimes the most routine situations require the most extraordinary interventions. Sometimes concealing your capabilities ensures you're present when those skills become essential to saving a life. Every day around the world, former military personnel are trying to integrate into civilian life. Often their skills and experiences are overlooked or misunderstood. Lisa's story is a reminder. Every veteran carries a treasure chest of skills, experience, and character. Sometimes the greatest heroes are hidden in the most unexpected places. Sometimes the person needed to save a life is already there just waiting to be recognized. If this story moved you, share it, subscribe, and help these important stories continue. We'll see you in the next legend. And until then, remember, your healthcare provider might have saved more lives than you'll ever know. Service never stops.